Thank you very much for both Tower and Bentley company. Very excellent work and expansion. Any question for anyone for the company, or shall we delay the question? Anyone has a question for them? Okay, so now we are welcoming Prof. Richard Barr for his presentation. He will talk about lever shear wave elastography, lever principle and clinical application in chronic liver disease, quantification, fibrosis, and steatosis. So Prof. Richard, he's a radiology consultant. He's a professor of radiology in Northwestern Ohio Medical University since 1995 up to date. He's a professor of radiology at Northeast Ohio Medical University. He participated at the Southwestern Imaging and Northside Medical Center in Youngstown, Ohio. He reviewed his BS in chemistry at Ohio State University. He had also the PhD in organic chemistry and at Michigan State University, and his MD from Case Western Reserve University. Dr. Barr has published over 100 peer-reviewed papers, several books, chapters, and book on breast elastography and book in elastography principle and approach. He has presented over 300 scientific presentations and invited lecture worldwide. He has been individual in elastography and ultrasound contrast for over 15 years, presenting multiple presentations worldwide in this subject. So we are welcoming you, Prof.
Thank you. So I have worked with many companies. So what I'd like to do for this talk is review the principles of elastography, discuss how elastography can be used to establish liver fibrosis, decreasing the need for liver biopsy, learn how to perform shear wave elastography, and to describe how to incorporate elastography into your clinical practice. So chronic liver disease is a substantial worldwide problem. Its major consequence is increasing deposition of fibrous tissue within the liver, leading to the development of cirrhosis and its consequences of portal hypertension, hepatic insufficiency, and hepatocellular carcinoma. The stage of liver fibrosis is important to determine the prognosis, surveillance, prioritization for treatment, now that we have treatments that can reverse this process. So when I was in medical school, I was taught that cirrhosis was not reimbursable, but we now know with appropriate treatment that fibrosis is dynamic, and regression of fibrosis is possible with treatment of the underlying condition. Previously, the only method of staging the degree of fibrosis was liver biopsy, and chronic liver disease can be caused by several etiologies that I've listed here. Liver biopsies can assess both fibrosis as well as inflammation and fat content. There are numerical steering systems or non-quantitative ordered categories. There is actually a lot of pathology variability, and some studies show that the correlation of pathologists is actually not very consistent between sites as well as within the sites. To have an adequate specimen for analysis, you need to have a greater than 2 centimeter biopsy with greater than level portal triads. If you have a smaller sample, you usually get less fibrosis. And again, this is an invasive procedure with severe complications in up to 1%. It represents only 1/50,000th of the liver volume. And again, there's considerable inter-observer variability with pathologists with kappas of 0.4 to 0.9. And often they can be off by 2 stages. So as we go to looking at liver fibrosis, the liver biopsy is really an imperfect standard, and it'd be very difficult for us to correlate this with biopsies. The American Association for the Study of Liver Disease recommends for biopsy a 16-gauge needle that's at least 2 centimeters long, and again must contain 11 or more portal triads. There are several different scores. The most common are the Metavar score, which goes from 0 to 4, and then there's the Ishak score that goes from 0 to 6. And I'm not going to review those for sake of time. But here's some pathological specimens from F0 to F4. And you can see that depending on where the samples are taken, there could be variability in the pathology. So in this F4, if we would have sampled more up here, you can see that we would have had a lower grade, where in this lower sample, if we would have graded here, we may have had a higher grade. So pathology is not always very good. So the Society of Ultrasound and Radiologists had a meeting with both radiologists, pathologists, hepatologists, and basic science people, and this slide summarizes everything that we talked about. We have pre-test probability and post-test probability, meaning that if we use cutoff values, it really depends on your population. If you have a population that has a very high chance of having cirrhosis, you don't want to have any false negatives, so you want to maybe decrease your cutoff values. Whereas if you're looking at a normal population, you may want to increase your cutoff values, because false positives in that situation are very bad. Again, we have multiple etiologies that all lead to fibrosis and onto cirrhosis. Things that can affect the measurements are age, gender, ethnicity, and lab tests. We have patient factors of obesity, ascites, medications, and fasting. Other comorbidities of the patients of acute and chronic disease or vascular congestion. And then we have multiple methods of doing elastography. Now we have MR and several types of ultrasound. And we can have variability in the measurements based on the hardware and software of the systems, as well as the experience of the sonographer and the person interpreting the exam. So again, we talked about this cutoff values. You need to really look at it if your cutoff values correspond to your population. Because if you have a very population with a very high prevalence, you don't want to miss any, and so false negatives are bad. And if you have a low prevalence, false positives are bad. So you may have to adjust the score, but we're going to talk about as we go through this another way of evaluating these measurements. So from an American standpoint, the hepatologist asked the radiologist to basically put people into 3 groups. No or mild fibrosis, where there's no immediate treatment and just follow up based on the clinical factors. Mild or moderate fibrosis, treatment based on the etiology and follow up based on clinical factors. So in the US, we don't treat hepatitis C with antivirals until they reach some level of fibrosis. So this group would be where that person falls. And then severe fibrosis or cirrhosis, where we have to start screening for hepatocellular carcinoma. They would also like us to tell them if the patient is compensated or decompensated, and if they're compensated, can we assess if they have normal portal pressures or abnormal portal pressures. Well, there's 2 types of elastography: strain, which we're really not going to talk about because it doesn't work well in the liver, but we'll talk about it extensively when we talk about breast. And we have shear wave, which is quantitative, and there's 3 types available now in ultrasound. 1D shear wave, which is a mechanical push, which is FibroScan. We have point shear wave using ARFI, and we have 2D shear wave using ARFI. So the point shear wave looks at a one focal area at about a 1 centimeter area and gives you a measurement. The 2D actually is a much larger field of view where you can then put ROIs within that to get a measurement. Just briefly, again, strain has limited literature. Hitachi has a machine. Most people do not favor this, and it's not listed in any of the guidelines. Again, we have 1D point shear wave and 2D shear wave, and there's magnetic resonance imaging, which I'm not going to talk about today. So with the techniques we use, acoustical radial force impulse, or ARFI, and you all know that ultrasound pulses can be reflected, absorbed, or attenuated, or they can be momentum transfer pushes. And this ARFI pulse is generated so that it provides maximum momentum transfer, so it causes the tissue to move, and that has 2 consequences. We can look at the measurement directly, which is strain imaging, or we can look at the lateral or transverse shear waves. The speed of those shear waves is proportional to the stiffness of the tissue. This little cartoon shows what's happening as we start again, you're going to see a high attenuation, red pulse, and it's attenuated as it goes through the liver, and you can see that after a couple millimeters that the shear wave is already attenuated. So this is a very small area that we're doing these measurements, so motion is very critical because we're looking at only a couple millimeters to do the measurements. And what happens is we get these series of curves, which you don't see, it's done in the back of the machine, that we use B-mode imaging to track those shear waves. So the B-mode that's closest to the RF pulse is going to have the strongest pulse, and it's going to curve faster. And we get this family of curves, and if we take the peak versus the time that it took to get there, we get a slope, and the slope of the line is the shear wave speed. So the critical thing here to remember is that we're using B-mode actually to track the shear wave. So if you have a very poor B-mode image, then you're also going to have a very poor shear wave measurement. And again, there's two types of RF technology, both of which are present on the Mindray system. Point shear wave, again, we take a measurement in a single fixed ROI. It's about 1 centimeter. And this can be taken in series in one breath hold on the Resonance 7, and we can maybe demonstrate that during a break. The 2D shear wave is measurements over a much larger field of view, and then smaller ROIs can be placed to obtain liver stiffness values. And in this one, we can change the ROI size to average more of the liver. So here's a representative image of a point shear wave, and we're going to talk about where to put the box and how to do the study shortly. But again, you can put this box, and here you can see we've done multiple measurements in one breath hold, and it gives you the mean stiffness value. And this little table actually is quite nice to show you how reproducible the measurement is, because if they are non-reproducible, these will be of different heights. It'll give you some idea if you're getting good measurements. In 2D shear wave, again, we have this larger ROI box, or field of view box, and we can put an ROI within it. There are two things, let's go on how to perform the exam. So you're always going to use a right decubitus approach, and the reason is that we want to keep the transducer perpendicular to the liver capsule, and we have problems with the left lobe of the liver because of cardiac motion. So it's very hard to get accurate measurements in the left lobe of the liver. We want to have the patient in a supine or left lateral decubitus position. We're going to have the patient raise their hand above their head, and by that I mean way up high so that you can actually increase the rib space to get a better window. You may even have the patient bend like a banana a little bit, again to get a little bit better window to get into the liver. And again, we're using B-mode to track the shear wave, so we really want a good B-mode image. We want to find the best window without shadowing, regardless of the liver segment. And in general, you're going to have your best window in segments 5, 7, and 8. You want to keep the transducer perpendicular to the liver capsule, because if it's at an angle to the liver capsule, a lot of the energy is refracted off the liver capsule, and we have weaker RF pulses into the liver, which give you more noise within the shear waves, and therefore less accurate measurements. You want to avoid large blood vessels and bile ducts, because again, these are regular ultrasound waves. They hit the walls of these vessels and bounce back, and we get an interference pattern of the shear wave going in two directions. We see reverberation artifact in the first 1.5 to 2 centimeters from the liver capsule, so we don't want to take our measurements there. And again, cardiac motion always affects the left lobe of the liver, and in general, it's very almost impossible to get good, accurate measurements from the left lobe of the liver. So again, what we want to do is place the transducer parallel to the rib space and perpendicular to the liver capsule. You do not want to place the transducer across the ribs. You don't want to angle the probe to the liver capsule. You don't want to use substernal scanning, and no angling to evaluate the left lobe of the liver. You also don't want to put the ROI box very deep, because again, the RF pulse is attenuated as it goes through the liver, and therefore it's weaker as you go down in the liver. So the ideal position is about 4.5 centimeters from the transducer, but still maintaining 1.5 centimeters from the liver capsule. You don't want to obviously put the box over vessels, and you don't want to angle to the liver capsule. We want to have the box perpendicular to the liver capsule. Again, that'll give us the most energy into the liver and better measurements. The system on the Resonance 7 has a couple things that will really help you evaluate these things. And I think in the past, without these, we had a hard time because it was very hard for us to know if the measurements were accurate or not. So we have a stability factor that's up here, the stars. So you would like to have 5 stars. If you can't get 5 stars is acceptable, but ideally you want to have 5 stars. This is telling you that there's no motion in the liver as you're doing the measurements. And the other thing is we have what's called a quality map. And this map is green, which is high quality, yellow, which is poor quality, and purple, which is very low quality. So again, what this does is it looks at those curves that I showed you and decides if we have accurate curves to give you a good measurement. So in the past we didn't have these, and I think you could have gotten a bad measurement even though you thought you had a good measurement. The other thing you can see in this slide is I put the field of view box towards the liver capsule, and you can see that we have these very high readings in the first 1.5 centimeters from liver reverberation. So you always want to put your box below that for your measurements. And in the 2D shear wave, we can see this artifact, but if you're using the point shear wave, you don't know where this is at. So it's very important that you place the ROI at least 1.5 centimeters below the liver capsule. And again, you don't want to do angling. Sometimes you can get very high measurements. So here we got at least 4 stars. And although this tells you that we've got good shear waves, we're really doing this as a poor exam, and these measurements are probably inaccurate. So 5 stars in green is not adequate. You still have to make sure everything else is done properly. Again, you don't want to go too deep, and here you can see as we go very deep, we just don't have enough energy to generate shear waves we can measure. And oftentimes when we angle the probe a little bit, the sides, about 10 or 15% on either side of the field of view box in the 2D, often have artifacts. So again, the best place to take your measurement is in the center of the field of view box. So again, this is kind of our protocol. We try to be perpendicular to the liver in both planes. So not only superior and inferior, but right to left. And stay the top of the box about 1.5 centimeters below the liver capsule. The most important factor we have is breathing. Measurements taken during patient or scanner motion are number 1 inaccurate. It's really important to control the breathing. And as you take a breath in, or you do a Valsalva, you increase your right heart pressure, which is transmitted through the hepatic vein. The liver actually becomes stiffer. So actually the liver stiffness varies as we breathe. So what we want to do is try to take our measurements in a consistent breathing, and usually in somewhat neutral position. So actually, like on 2D, you can actually be watching the liver as it moves up and down, and you want to pick a position that's somewhat neutral, and try to do that same positioning on all your measurements, because if you do different respirations in or out, you're going to get more variability in your measurements. So we usually talk to our patients when we start and explain to them, when we say hold your breath, we want them to stop breathing, because most people, when we say stop breathing, do a Valsalva, take a deep breath in. So we try to explain that to them so that they understand, and we work with them so that when we say stop, they just stop. And all our measurements can be done now in a very short amount of time, so most people will be able to hold their breath. These are images of one of my sonographers taken just less than a minute apart, and here she's normal, doing normal breathing and normal neutral respiration. I had her do a Valsalva, and here you can see she became cirrhotic. So this respiration can really change the measurements drastically. I don't want to go over this slide in great detail, but there's a lot of potential system variables, and this gets to the point that you may get a different value if you use a different ultrasound system. And there are many reasons for this. The most common is that each vendor has its priority transducer that has a bandwidth and a central frequency. And the shear wave speed is proportional to the frequency of the RF pulse. So there's some variability between vendors. And as you have a large bandwidth, as most transducers have, that the higher frequencies are attenuated faster. So actually, we'll talk about this a little bit later, that actually, depending on the depth of the measurements, you can get different variables. And again, each vendor has their own reconstruction algorithms and different ways of doing this. So there is variability between systems. There's an effort called KIBA, Quantitative Image Biomarker, that's a association of the RSNA, the FDA, physicians, and some basic scientists, as well as the vendors. And we generated phantoms that we were able to evaluate all the vendors and been able to provide that information to them. So they're slowly being able to correct their system so that number one, they get an accurate measurement, and number two, we have more uniform results between vendors. So I think right now, after the study and people have varied things, there's probably about a 10 to 12% difference possible between one vendor and another vendor. And again, I look at this as the RF pulse strength is what's really critical, because the stronger the RF pulse, the stronger the shear waves, the easier it is for us to measure them. So again, we have attenuation problems. So if you have steatosis or a cirrhotic liver, this is going to attenuate the RF pulse more. So these are the patients that you're going to have a hard time getting good measurements in, because we just don't have enough energy to penetrate those very stiff livers. And those are the ones that are going to be very challenging to you. And again, we did some work that I'm in the process of writing up. If we look again, here's that nice family of curves that we use to calculate the shear wave speed. You can see I put this, what I believe is perpendicular to the transducer. But if we angle the probe, and this 35 units was the peak of the shear wave, the maximum shear wave we saw when we did things correctly. If we just angled the probe by 10 degrees, that maximum was 13. So we lost more than half of the shear waves by just angling the probe by 10%. And if we did it by 20%, we're now down to almost a quarter of the energy. And you can see that we don't have the nice curves that we had here. They become very distorted. And again, you can see the measurements very drastically. So it's very critical that you keep the transducer perpendicular to the liver capsule. Other variables that are going to affect the measurement are acute and chronic diseases. And you have to remember that we are measuring liver stiffness, not liver fibrosis. So inflammation causes increased stiffness in the liver. So anyone that has an acute hepatitis is going to have very high values, but you're going to overestimate the degree of fibrosis if you use the tables because of the inflammation. Multiple disease etiologies can also give you artificially high fibrosis values. When we eat, we increase the blood flow through the portal vein. It actually increases the liver stiffness. So we usually fast our patients for 4 hours before we do the measurements. Again, we don't want to sample near or on vessels or bile ducts. We don't want to sample within the first 1.5 centimeters from Glissen's capsule. And we don't want to sample at the edge of the sector. And again, we're using B-mode imaging. So you never want to take a measurement where there's shadowing, and you really want to try to get the best, strongest B-mode image, because that's telling you that you're getting in a lot of the energy and you're going to have better shear waves, so we would have more accurate measurements. Again, we're not going to sample the left lobe of the liver, and again, controlling both patient and scanner motion is very important. Other things that can affect the measurements are congestive heart failure or renal failure with fluid overload, because again, you have increased right heart pressure, and that's transmitted through the hepatic veins to the liver. So the liver will be stiffer, not because of fibrosis, but because of the increased right heart pressure. Again, exacerbations of acute hepatitis, and usually if we look at the transaminase levels, it has to be about 5 times normal before it significantly changes the measurements, and again, ingestion of food. Extrahepatic cholecystasis use of beta blockers, which again can change the portal pressures, and doing a Valsalva, all can affect the measurements. In general, steatosis does not affect the liver stiffness value the way we have the machine now. It does affect the value if you change the RV frequency. And right now you're not able to do that, and in the future we may actually do that to actually quantify the liver steatosis. So again, things that you have to really control very well are excessive motion. So both the patient motion and sonographer motion. Tissue attenuation, subcutaneous fat is going to artifactually weaken the RV pulse, or really decrease the RV pulse. So you're going to get more air in your measurements, and again, a stiffer liver is going to also cause attenuation of the RV pulse, which gives you more air in the measurement. Again, you need to have a good window with no shadowing. These are the results from a study that I did with Dr. Ferrioli from Italy, where we looked at 7 different ultrasound systems, as well as the FibroScan on the same patient. So we did 22 patients, and 4 of us scanned those patients. And here you can see the variability between the systems. The red line is the FibroScan. We use that as a reference. And what we found was the 2D RV systems tended to work much better and track the FibroScan versus the point shear wave systems. And part of this again is as we get to stiffer livers, you can see that there's more variability between systems. And again, this relates to the strength of the RV pulse. Some vendors have a stronger RV pulse than others. If we look at the data differently, these are the results of the 7 vendors. This is if we look at all of the data. But if we look at less than 15 kPa, so just below cirrhosis, you can see they're actually not that variable. So the system variability really occurs mostly in very stiff livers. So should we take measurements in the same location or various locations? This table is what we call a bias table. It's what we did with the Kiva Kiva system. What we did is we had 3 phantoms with a velocity of 1.1, 2.3, and 2.9 meters per second, and we did the measurements at 3 centimeters, 4.5 centimeters, and 6 centimeters. And this was from phase 1. And in this vendor, if we had a 2.9 meter per second stiffness liver and we did the measurement at 4.5, they were accurate. But if we did that same 4.5 centimeter in a normal liver, 1.1 meters per second, they underestimated it by 15%. So after this first round, the vendors went back and did corrections into their system and factors to make this better. I think, again, right now, the maximum variability is about 10% within a system. But again, changing the depth is going to give you different measurements. So you want to take all your measurements at the same depth. And we like to take it at the 1.5 centimeter below liver capsule so that everybody in the lab is doing the same thing. And if the patient comes back, we're going to get more consistent measurements. How many measurements? So for point shear wave, all of the guidelines recommend we take 10 measurements. There are some papers that showed if experts doing this, you can maybe get away with 6 or 7 measurements. We use the mean value, not the average, and the mean kind of gets rid of the high and low values. And we use what was developed for the FibroScan, that greater than 60% of the measurements are good measurements. So in the point shear wave, you may get XXX or 000, meaning that the system couldn't calculate a shear wave speed. Or on the 2D, you're going to get no coloring or purple. So those are not good measurements. And if you did 10 measurements and 6 of them were bad, that means that you're just never going to be able to get good measurements in that patient. You shouldn't take 20 or 30 measurements and try to get 10 good ones, because probably the ones that you think are good are probably inaccurate also. So this is going to happen in a very steatotic patient, a very high BMI patient, or a very cirrhotic patient. And then those patients, you just have to say that the technique can't be used to calculate an accurate shear wave. Another thing we use is the interquartile range over the median. and less than 0.3 or 30% suggests this is a good data set. This tells you that your measurements are all very close to each other and you have a high probability of having a good measurement. So I like this because I can monitor our sonographer quality. When we started doing these routinely about 2 years ago, I think our technologists had a IQR over median of 0.2 to 0.3. We're now between 0.1 and 0.2. So over the course of time, I can see that our lab is getting better, and I can look at each of our technologists. I understand which ones are doing a better job and which ones need a little bit more training based on the IQR for medians that I see from them. So again, I use this to evaluate our lab and make sure that we're continuing to improve. For the 2D systems, the WFM guidelines, which have just been released, recommend we only need to take 5 measurements if you have a quality measure as it's on the Resonance 7. And again, you're going to use the IQR over median to suggest the data set is good. Let's get that behind. So how to perform the real-time 2D shear wave with quality assessment on the Resonance 7. So again, I told you we've got several things that we're going to help you understand if you have a good measurement. So we have the stars, which basically tell us if the patient is breathing. So again, ideally we would like to have 5 stars. We have our map, that's the velocity map, usually set at 30 kilopascals, which is probably good for almost all patients, unless you have a very steatotic, or excuse me, a very cirrhotic patient. They may have values above that. You may need to adjust the scale. But in general, for 95% of your patients, you don't need to adjust the scale. And then again, we have our quality map. Green is high, yellow is poor, and purple is very low. And then we get our measurements. So what I like to do is I like to get a cine clip of about 6 or 7 seconds with the patient holding their breath. And then I review that cine clip and look for the areas that have 5 stars. Ideally, I'd like to have several frames look the same to do our measurement. And then once I get my 5-star area, then I pick one of those frames, and then I look at the quality map to decide where to put the ROI. You can have 5 stars, and you can have some areas in the map that are still poor quality. And again, here's a bad case. We only got 2 stars. We put the box in the wrong place, and you can see we've got very low quality. So again, you shouldn't save this measurement. Any measurement you take here is going to be inaccurate. And again, having 5 stars and a high quality doesn't assure you that you still didn't make merit. You have to do everything correctly. So here in this patient doing a Valsalva, who should be a normal patient, even though I got 4 stars and a high quality, I know because the patient did a Valsalva that these measurements are artificially elevated. So step by step, we usually do our standard ultrasound examination. We find the best intercostal window, position the transducer perpendicular to the liver capsule, avoid large blood vessels if possible, have the patient suspend respiration in a neutral position, and again, obtain a 6 to 8 second clip, find the best 5-star image. Again, if you have several frames of the same, that increases your confidence that you've got good measurements, and then look at the quality map to find the area with the highest quality and place your ROI there. And again, since we're doing 2D, you can use only 5 measurements and then confirm that your IQR over median is 30% or less. The system will give you a report page that gives you the depth that you took the measurements, the diameter of the ROI, the mean KPA of the liver, and down here it gives you the median and the IQR and the IQR over median. So here it's 17%, less than 30%, so we think these are good measurements. And this patient had a KPA of 35, which is obviously quite high in a cirrhotic liver. So moving on to interpretation. This graph shows you from a large meta-analysis that was done by Friedrich Wurst. Instead of plotting and looking for cutoff values, what we did was plotted for a given shear wave speed, what was the probability of a Medivar score. So let's look at 1.3. So at 1.3 meters per second, you can see that you have about a 1 or 2% chance of being F0. You have a 10% chance of being F4, a 20% chance of being F3, and a 35% chance of being F1 or F2. So you can see from this, we do really well in normals and really well in highly abnormal patients. But this middle range is overlap, and no value is even over 50%. So realistically, it's unlikely that we would ever be able to distinguish between F1, F2, and F3. And again, remember we're measuring liver stiffness and not fibrosis. We need to control all those factors when we do that. Now the SRU, which is now several years old, printed out these tables, and the recommendation was, instead of using the Medivar score, we'll have two cutoff values. A low cutoff value below which you have a very low probability of having advanced liver disease, a high probability cutoff value where above that value you have a high probability of having cirrhosis, and then this middle group that's not normal, but it's in the middle range. At that time there were fewer vendors. These were the measurements that we gave for each. We also went through the literature and gave cutoff values for Medivar scores, because some of our hepatologists still like to use those. Another interesting thing that we mentioned in the new WFM guidelines, and we didn't give cutoff values at all in the WFM guidelines because we think that's probably not the appropriate way to look at this data. There is a conference called the Bevino Conference with hepatologists, and they published a nice little scheme that the transient elastography less than 10 kPa in the absence of other known clinical signs rules out compensated advanced chronic liver disease. Values between 10 and 15 are suggestive of chronic advanced liver disease. Values above 15 kPa are highly suggestive of compensated acute chronic liver disease, and values between 20 and 25 or higher can rule in clinically significant portal hypertension. So we gave this chart. So basically, 5 kPa and below is normal. Between 5 and 10 kPa, you're probably normal, but you may want to do an additional test, a blood test, to confirm that you ruled out compensated acute chronic liver disease. Between 10 and 15, there's a higher probability of having compensated acute chronic liver disease. So there you may want to do a blood test to rule in chronic acute liver disease. And then above 20 kPa, you're going to rule out, you can be relatively sure that you have advanced chronic liver disease as well as elevated portal hypertension. So when I report things, I usually report the liver stiffness value is whatever the kPa is, and we use the SRU consistent with no or mild, moderate to severe, or severe to cirrhosis. If you want, you can give the IQR over median. I usually don't give it unless it's abnormal. And then I usually add these little qualifiers. So in the setting of elevated liver function test, the patient ate, congestive heart failure, etc., the degree of liver fibrosis may be overestimated. And again, if the variance in the measurements is large, the IQR over median greater than 30%, the accuracy of the measurements may be in question. When we do treatment for hepatitis C with antivirals, what we'll notice is a very rapid decrease in the liver stiffness, and that's felt to represent resolution of inflammation. And then we get a slower decline over the course of months to years. That's resolution of the fibrosis. Some interesting work has been done looking at the spleen in patients that have cirrhosis. And preliminary studies suggest that spleen stiffness may correlate with portal pressures. Here's one of these studies, and what they found was with a cutoff value of 3.18 meters per second, that there was a high chance of these patients becoming decompensated from their cirrhosis. With focal liver lesions, both benign and malignant lesions can be soft or hard to the normal liver. In addition, the liver stiffness varies based on fibrosis. And I like to point out the Stephanie Wilson's paper where she looked at multiple lesions, and what she found was, yes, malignant lesions are stiffer than benign lesions, but if you look, there's quite a large overlap. So there are soft HCCs and hard HCCs. There are hard fibroadenomas, hemangiomas, and soft hemangiomas. So in a given patient, we really can't use this to distinguish if something is benign and malignant, although there are some literature that we may be able to distinguish FNH from adenomas. So this is one of our patients that has diffuse metastatic disease from colon, and one of the Mets is very stiff and one of the Mets is very soft. So even within this one patient, you can see marked variability in the stiffness value of liver lesions. So going back to what our hepatologists want us to tell them, using the SRU and our regular ultrasound examination, we can tell them no or mild fibrosis is a stiffness value of less than 5.7 kPa. Mild and moderate fibrosis is between 1.37 and 2.2. And stiffness values above 2.2, which is 15 kPa. The patient has severe fibrosis or cirrhosis. They need to now be screened every 6 months for hepatocellular carcinoma. If we see that they have ascites, varices, or recannulated umbilical vein, we can tell them that the patient's decompensated. If we don't see those, we can say the patient is compensated, and we can give them some idea of the portal venous pressures. If they have a normal spleen and portal vein, we can probably say that they don't have elevated portal hypertension. If they have a stiff spleen, dilated portal vein, or large spleen with varices, we can say that they have elevated portal pressures. So basically what we did is, when I show you that likelihood ratio, our cutoffs are like this. So again, we have this lower cutoff value. Almost all the people below this level are normal. They're either F0 or F1. We have the high cutoff value above this level. Everybody is probably F3 or F4. And then we have this group in the middle that's a combination of the others. So to conclude, to obtain accurate liver stiffness measurements, adherence to a strict protocol is required. And again, we try to have all of our sonographers and physicians do exactly the same positioning of the patient, positioning of the ROI, so that we get consistent measurements. And remember that both patient factors and screening factors affect results. And the more you can control those and understand those, the more consistent results you're going to have. Thank you. Questions?
Yes.
Yes.
Three short questions. Thank you very much for this good and excellent presentation and very useful to me. My name is Mohamed Ramadan. I'm a radiologist, General Directorate of Radiology, Ministry of Health, Training Section. Three questions about the training. To be a well-trained radiologist or sonographer in elastography, how many hours I need to be well-trained?
So
Average.
I think I spent a lot of, initially I was doing these by myself before it was approved by the FDA. So they were kind of research patients. When it became approved, we started training our sonographers. And what I did was I told them to do it on every patient, even if they were not ordered. Because you need to get, it's like riding a bicycle. So the more patients you can do and see that you're getting consistent results, the better it is. So we started for several months to have them do every patient to feel very comfortable.
Okay.
Like I said, if we look at the 2 years we're doing this, I think it took maybe 6 months for everybody to be comfortable, getting relatively reasonable results with not a lot of problems.
Yes.
But even after that, I'm looking at that IQR over median, I can see that we're getting better and better consistent results with time. So it's going to take months to have everybody well-trained and feel comfortable, but the longer they do it, I think the better they get. And again, it's learning how to work with the patient to get the good measurements. And also, when we started, we didn't have the quality measure, we didn't have all these other things, so it was even more critical for us to try to figure out, was the patient doing what we told them to do?
Yes.
Now it's a little bit easier with these additional factors that help us decide that there's no motion on the patient and that we've got good shear widths.
Here in Saudi Arabia, radiologist working in ultrasound machine and also sonographer and even radiographer with experience. Liver elastography according to the standard or policy in US for radiologist or even sonographer or any person well trained in sonography can do the exam.
Any patient that's well trained and knows how to do the elastography. So in general, physicians very rarely scan. In the US, it's almost always the sonographers.
The ideal radiologist or sonographer, the ideal.
Anyone can scan, but in general, it's mostly the sonographer. So usually, the sonographer does the case. If I think there's a problem, I will go in and scan. But in general, most of the cases are just done by the sonographer.
Okay. Last question. The whole time scan for the patient if patient requested. Because I know it's need more time for liver elastography.
Right,
Yes.
and again, this is the training. So I think initially it took them 15 minutes to do the elastography. Now it's probably less than 5.
Yes.
So as they get used to doing it, they do faster and faster. So we don't actually give them more time from doing a regular abdomen, because we give them, I think we have half-hour slots.
Yes.
And we finish before that, but we do that so that if patients are added in, we have time to add the patients in.
Thank you very much. Thank you.
One problem thing is if you have a very steatotic patient or a cirrhotic patient, it does take you longer to get good measurements because you're going to struggle to get an area where you have good measurements.
Shukran.
We have to move to the second talk. Thank you very much.